Good morning. Welcome, friends. I'm Dr. Malia Jones. I'm the editor-in-chief here at Dear Pandemic, and I am also a social infectious disease epidemiologist. I'm joined this morning by Sandra Albrecht, who's a fellow contributor here at Dear Pandemic. Dr. Albrecht is an epidemiologist. She's a member of faculty at Columbia Mailman School of Public Health, and she is the editor-in-chief at the Dear Pandemic Spanish language mirror site, Querida Pandemia. So thanks for joining me this morning, Sandra. It's your first time.
Yeah, it's my first time joining you guys. I get told, Malia, like Saturdays tend to be tough with the young kids and stuff, but I was like, let me just try it out, do this once, see how it goes.
Yeah,
have some fun
we're so
with
happy
it.
to have you.
Yeah.
So we have a huge thank you again this morning to Bridges for the Deaf and Hard of Hearing for providing live closed captioning services by Lucinda Plexico, and we have ASL interpretation by Jeannie Settlemeyer. So thanks very much for joining us, and thanks to Bridges for helping us with those services. That is going to be available for 2 more weeks until the end of February for sure. And after that, we would love to keep supporting it. And we would love to know if you are still using those services. So if you can let us know in the comments, that would be really helpful.
And then just to let everyone know that Dear Pandemic has a newsletter. You can now sign up to receive a quick digest of our most popular posts twice a week at the top of our website at dearpandemic.org/subscribe. And also a reminder that we don't take questions cold. If you have a question, you can submit it in the question box on our website at www.dearpandemic.org. And while you're there, you can try and search for your question. All right, so let's get started here. So Malia, we got a question from Esther from Boston. I hope I'm pronouncing her name right. And the question is, we're considering getting budgies as pets. Is there any chance they could transmit COVID?
Yeah, so we all had to Google what a budgie was. It turns out it's a parakeet. Here in the United States, many people call them parakeets. So the answer to your question, Esther, is no. We have had a few dozen instances where a dog or a cat or some other mammal pet got COVID. But even among those rare instances, we've had no case where the animal passed COVID back to a human being. And I looked it up. In the US, we've had 7 tigers, 3 leopards, 3 lions, 3 gorillas who've been infected, as well as 58 cats and 41 dogs, but 0 birds. Really, the only animals that seem to be highly susceptible to COVID-19 infection are in the weasel family. And yes, that does mean that owners of ferrets need to be really careful, but your birds should be fine. So I think I've got the first question or the second question for you, Sandra. We got this one from Allison in Fort Worth, Texas. And Allison asks us to help her settle a debate with a friend. Does the 95% efficacy rate for the vaccines mean that even if exposed, you have a 95% chance that you will not contract COVID-19? Or does it mean that if you contract COVID-19, you have a 95% chance of surviving it? What does that 95% number really mean?
So this is a really, really great question. And I know that this is an estimate that tends to be misinterpreted pretty often. So I'm glad it was asked. So first, I just wanted to open with what the correct interpretation is. So in the case of the Pfizer trial, as an example, the interpretation is that the people that got the vaccine had a 95% lower risk of developing symptoms from COVID than people in the placebo group. And so after this interpretation, I do want to focus on 3 key points that that I want to clarify, and I think are important to better understanding around what the efficacy estimates mean. So first, these estimates that we've gotten from the clinical trials are not estimates of one's own risk of getting COVID or getting infected with COVID, of getting sick from COVID, or of dying from COVID. So we shouldn't be using these estimates to assess our own risk of any of these outcomes. And the reason is because the estimates of risk from these studies are actually derived by taking the average of the risk across a bunch of people. So it's not a number that's meant to describe one person's risk of any outcome. An individual's person's risk of COVID can be higher or lower than what was found in the trial. But we generally don't try to apply the risk that's calculated in the study to characterize the risk for any one person, because again, those numbers are intended to reflect the average across a group of people. And the second point that I wanted to make is that the efficacy that gets reported is itself not a measure of risk. So that 95% efficacy number that's reported is not meant to describe the risk even in a group of people. What it is, though, is a comparison of the risk across different groups. So what we do in these trials is we take the average risk in the vaccine group and then the average risk in the placebo group, and then we do some math with these numbers to determine what the percent difference in risk is of the COVID outcome. So we compare the vaccinated group to the placebo group. So it's a comparison. It's not itself a measure of risk. And just to emphasize too, because the person asking the question wanted to know if it's a measure of my risk or someone else's risk. And the point that I really wanted to make is that it's really comparing two groups of people. And in the case of the Pfizer trial, it's comparing, whether or not people developed symptoms of COVID. That was the outcome that was studied, and it showed that people who were in the vaccine group had a 95% lower risk of developing those symptoms than the placebo group. And then just the final point that I wanted to make, what's sometimes challenging for interpreting these efficacy estimates is that some of the trials measured different outcomes.
Right.
So as an example, the Pfizer trial looked at symptomatic disease. And that's why we can't assess the efficacy of the vaccine against COVID infection, because that's not what was studied. What they looked at was symptomatic illness. But some trials did look at COVID infection, and some trials focused on more quote unquote severe disease. And they have their own definition of what severe disease is, and that can differ across the trials also. And then some trials also looked at hospitalization as part of the outcome. And so I say this because it's really important to have this information to know what the outcome was to better interpret that efficacy estimate. And then we also want to know who the comparison groups are. What are the two groups being compared? And this information is useful so we are better able and better equipped to interpret the efficacy estimates from the different trials.
Right. Yeah, and so if this is a real challenge with, in public health and epidemiology, we study groups of people. And this idea of when, can we apply the average for a group to any one individual person? You really can't. And so it's not about, we got a really similar question from David from Westchester, Pennsylvania, which is very close to where I'm from, actually, High Westchester, that says, so does a fully immunized person have a 5% chance of getting COVID each time they're exposed? That's really not how we can interpret that number, right?
Yeah, exactly. So, I mean, all we know is that this group of people, the vaccinated people, had this efficacy for a given outcome, depending on the outcome that's studied in the trial and compared to the placebo group. So we really can't say anything about our own risk. And again, it all depends on what the outcome was that was studied in the trial.
Yeah. So I think one really important point to make here, though, is that what we can learn from these trial results is that the people who are in the vaccinated group have, on average, much lower risk of particularly death. In fact, we've had no deaths from COVID among any trial participant in any of the trials so far.
Yeah.
So they are very protective for that.
Yeah. All right. So we're going to move on to the next question. This one's for Malia. Jessica from Edgerton, Wisconsin, and quite a few other followers had a similar question too. So after the second dose of vaccine, how long will it be effective? I've read an article that says only 3 months. Please tell me that there are more optimistic studies out there.
Yeah, there are more optimistic studies out there. So what happened here was that last week, the CDC issued some new guidance for people who have been fully vaccinated about how to behave after you've been vaccinated if you are exposed to someone who has COVID. So you have a known exposure, what should you do? And what they said was that if you completed your vaccine series, and right now that means that you've had 2 doses for both the vaccines that are available here in the US. If you've completed your vaccine series, whatever completion means for that particular vaccine, and it was at least 2 weeks ago, but not more than 3 months ago, then when you're exposed to someone who has COVID, you don't have to quarantine. So why would they say this? To be honest, it's really confusing guidance. And I think what happened was essentially CDC updated the post-vaccine recommendation to match the guidance that already existed for someone who's recovered from COVID infection. I'm really not totally sure that that's an appropriate, it's not one-to-one. And I fully expect CDC to be changing this guidance at some point soon, because it's a little bit of a puzzle why they would have said this. The 2 big question marks are, one, what do we know about whether a fully vaccinated person really can get an asymptomatic COVID case and pass it on to other people? Well, not very much. I mean, you just said the outcome in these clinical trials was not asymptomatic infection. It was symptomatic disease. And so we actually just don't know very much still about whether someone who's vaccinated could get an asymptomatic infection and give it to other people. There is a growing collection of fragmentary evidence that really does suggest that vaccination reduces asymptomatic transmission. So that's great, but we don't have really firm evidence for this so far. The second question that this new guidance raises is the question that Jessica is specifically asking: does the vaccine wear off after 3 months? So why does this recommendation have an expiration date of 3 months post-vaccination? No, it doesn't wear off after 3 months. There's really no reason to think that it does. We don't know precisely how long protection will last, but some of the clinical trial participants have been followed for 9 months now, and their immunity has not evaporated. I think CDC took a sort of puzzling tack in issuing this guidance, where they went with the cautionary principle for the 3 months expiration, but not the cautionary principle for the asymptomatic transmission question. I don't know. I expect an update on this. I'm like next to 100% certain CDC will have to update this as new information emerges.
Yeah,
so
I mean, it's such a shame.
Short answer, no, it doesn't expire after 3 months. There's really nothing to suggest that happens.
Yeah, it's just hard when these recommendations come out like this, and especially without explanation. I mean, as scientists, we were confused, right, by these recommendations. And so I could imagine how the public is reacting to this. And so it's just unfortunate that this is the way these recommendations were delivered without more explanation. But yeah, I think I also expect this to change over time, and including, the idea too that COVID survivors only have they're immune for 3 months after. There's a lot of variability with that. So some people have antibodies for much longer than that. Some people have antibodies for much less than that. So 3 months is not this fixed cut point, but these are the recommendations that are being used by CDC. And unfortunately, it is leading to some confusion, but hopefully we'll get more clarification soon.
Yeah, so fortunately right now, there are not too many people out there who've had both doses for more than 3 months. And, by the time a majority of the population is in this situation, I hope that we have new and more sensible guidance. There is a related question in the question box actually about, will we have to be revaccinated after 3 months, or how will we know when we do? And that is actually a regulatory science question. Basically, CDC has a vaccine advisory committee called ACIP, and they have hearings about what's known about how long immunity lasts. They review these studies and make a recommendation for when we might need a booster, but it's not going to be every 3 months. All right, I've got the next question for you. Meanwhile, I need to remind our viewers that your questions should go in the question box at our website. It's dearpandemic.org, and the question box is a link right at the top. We don't take questions cold out of the comment box here, because we like to research our answers. So I've got the next question from you out of the question box, Sandra, for you. Sorry, you didn't ask this question. You're going to answer it. The question comes from Monica from the Philadelphia area. And Monica asks, what about people who are being super cautious? Basically eliminating risk by not sending kids to school in person, working from home, getting all your groceries delivered, seeing no one outside your household. For healthy middle-aged adults, is this too strict? And is anyone addressing this group and helping them be prepared to re-enter society? Their fears are serious, and they need to know when they can safely do what.
Yeah, all right. So there are a few points that I actually want to make about this, and it's a good question. So first, I think it's human nature to actually look at someone else and to see what someone else is doing and to think, well, you know, if that were me, I would be doing these things a different way. Or if I were young and healthy, I wouldn't be so strict about the mitigation measures that I use to minimize the risk of COVID. But I also think it's important to keep in mind that we don't always have the full picture of everyone's story. You know, someone can look young and healthy, but they might actually have underlying conditions that aren't clearly visible to others. Or even if they are healthy, they might have loved ones who are at high risk for severe COVID, and they have an arrangement where they're able to see loved ones who are at high risk. But it also means that they need to be very strict when it comes to the use of mitigation measures in other aspects of their lives. So to other people, it might look like they're being quote unquote overly cautious or too strict, but there may be legitimate reasons why they're behaving this way. So, so I wanted to mention this because even though it might seem like someone is being too strict, quote unquote, too strict, I think we also want to be careful about drawing conclusions or casting judgment without really understanding where people are coming from. And this does extend across the risk spectrum in terms of, you know, engaging in some of these mitigation behaviors. Some people, you know, we might be looking at someone else and think like they're being maybe too risky, quote unquote. And I'm not referring to people that are going to like crowded bars and that sort of thing. I'm talking about people who do take COVID seriously, but might be choosing to engage in, you know, mitigation measures that are different than what, you know, than what someone else is. And so I think, again, it's important to understand, you know, everyone's situation and not to sort of quickly cast judgment without really understanding where people are coming from. So that's the first point I wanted to make about this. And I just kind of wanted to open with that a little bit. And then just related to the point about what's quote unquote too much, like what restrictions are over the top, that's actually tough to answer because it depends on a lot of things. But one key factor is rates of community transmission. And this is something that we're going to have to continue monitoring over time. I know cases are coming down now. We have hospitalization coming down now, but we're still not at the lower levels that we would want to see. And we're still certainly not at the levels even that what we saw last summer, actually. So, you know, community transmission is something that we're going to really want to monitor over time and then act accordingly. And then also relating to what's, you know, what might seem like quote unquote too much, you know, it also depends on people's own risk tolerance. And that includes weighing the pros and cons of different mitigation strategies for each person. For some people, living in a way that seems too restrictive to someone else might actually be worth it to lower the risk of getting COVID for themselves or for their loved ones. But for others, behaviors that might seem too restrictive can also come with negative consequences like poor mental health, even poor chronic disease, especially if it means that they're not actually seeing their regular doctor to manage conditions that they have, or if they're not able to get out and exercise and move around. So, you know, it's a trade-off really. But what I would want is just for people to at least base their decisions on facts versus misinformation, right? And certainly this is something that we're going to continue to talk about and work on, especially as we move forward in the next phase of the pandemic.
Yeah, great points there. So you've got a question for me?
Yes, so I do have a question for you. So this is from Kesem from Florida. So the question is, I work for a healthcare company. We surveyed our employees to better understand vaccination status. But much to my chagrin, about 15% are not planning to be vaccinated and another 25% are unsure. what can we do to help those undecided to feel more comfortable with the decision to vaccinate?
Yeah, thanks, Kesem, for this great question. There are a lot of people out there wondering what can we do to help people who are unsure move towards vaccination. And I know, Sandra, you and I have both actually faced this within our own families, trying to nudge our own family members towards getting vaccinated. So this is not surprising to me. This is actually, these are rates that are comparable to what we're seeing in a lot of settings about vaccine hesitancy. There is a ton of hesitancy out there. Right now, our main issue with getting vaccines out there is not having enough vaccines, but I think we're soon going to reach a point where vaccine hesitancy is our main obstacle to getting to that, along that big picture end goal of herd immunity. So what do we know about vaccine hesitancy and how to address it? I have to acknowledge Allison Buttenheim, who is our collaborator here at Dear Pandemic. I'm going to crib from some of her talking points here. So we can think about the 3 C's of vaccine hesitancy if the framework is helpful. And those are confidence, complacency, and convenience. So I'm going to talk a little bit about each of these. Confidence is just how confident are people in this vaccine? How much trust do they have in it? And the key to do here is really to listen. It's not about convincing or persuading people in many cases. It's about asking questions with a sense of humility and honesty, asking people what are their concerns, and having an open discussion to bring those concerns to the table. We know a lot of people are getting their vaccine information from Facebook and other social media sites. And we also know, believe me, at Dear Pandemic, we spend a lot of time fielding questions and also dealing with comments that are essentially just, wild rumors about the vaccine, from microchips to infertility to conspiracies. There's a lot of bad information out there, and those scary stories really need to be dug up and examined and explored, I think, to overcome this and to build trust. In this population, a population of healthcare workers, I bet it's a lot of working aged women. And so issues around safety in pregnancy, breastfeeding, and future fertility may be particularly important to address. And if the answer is around lack of trust in the vaccine or the vaccine development process that stems from historical harms from racism or racial trauma, for example, like from the Tuskegee experiment, then I think it's really important to acknowledge that those concerns are, acknowledge them aloud, lay them on the table and name them, and acknowledge that those are real historical harms. The National Medical Association is a over a century-old professional organization of Black doctors, and they have very helpfully formed an independent task force on COVID-19 vaccines and come up with their own review of the risks and benefits and the science of developing the vaccines. And we're going to put a link to their site. They have a very helpful statement on the vaccines with particular attention to racial justice issues. And they do answer questions like, were there enough people of color in these vaccine trials? Were there enough people with chronic conditions? What are the issues around pregnancy and fertility? The second C is complacency. Complacency really is around that risk-benefit equation that we all make. Is this vaccine worth it for me personally, right? Is it necessary? And I think to address that, we should highlight why we're doing it. And it can be very helpful to share personal stories. So sharing your story about why you are getting vaccinated, why you're happy that your mother is getting vaccinated. You might ask some of your employees if they'd be willing to share their stories about their why and help get that positive message out. And then the third C is convenience. We really do have to make the vaccine easy to get and, if possible, fun. And this is Allison's big pitch. So, giving people a sticker, putting up a selfie station that is fun, offering a small reward if you can be really helpful. Making the vaccine process attractive, if at all possible, can be really helpful to nudge those people who just have a few, just need to be sort of tipped over the edge into getting involved in this project. So those are a few tips. You know, I think it's really important to listen. It's important to tell our own stories about why we are doing it, why it's important to us, and make it easy. So that is actually all we have time for today. We need to end a little bit early because Sandra has an important date with a music lesson and a 5-year-old. So I just want to tell everyone that we get a lot of questions. We got some this week that we just answered last week. So if we didn't get to your question, please do go look on our website, dearpandemic.org, and just search for some key noun in your question. It might be waiting there for you. I do read all the questions every week, and we use them to decide what we're going to post about in the upcoming week and on next week's live. So those really are useful for us. Please go put your questions in the question box. And another thank you to Bridges for the Deaf and Hard of Hearing for providing our interpreter and CART services so that we can be more inclusive and provide this info to more people. And if you've used those services, we'd love to know. If you just put a comment in the video feed, that'd be great. So thanks for joining us. Next week, it's actually going to be a really fun one. We are going to have a little town hall with the nerds at Dear Pandemic, your local epidemiologist and friendly neighbor epidemiologist. So that should be really fun. Get excited. Until then, stay safe and stay sane. Bye, Sandra.
Bye.